All right. Very good afternoon once again. A warm welcome to all the delegates, all the seniors here. It's a post-lunch talks on the 6th annual conference of the Telangana Ophthalmological Society. And to chair this particular session, we got chairperson. May I please invite Dr. Ashish K. Bansal. Hello, doctor, from Apollo Hospitals,
Hello,
Hyderabad.
everybody.
With this, I would like to invite our co-chairperson, Dr. Sandeep Grover, University of Florida, Jacksonville. Hello, Dr. Sandeep.
Hello, everyone.
And we got a very dynamic moderator with us, Dr. Vikas Mittal, LJI Institute, Ambala. Very good afternoon, sir.
Hi.
So I hand over the session to you. We got 7 minutes talk each speaker, and we'll reserve all the Q&A time at the end once all the speakers are done, and then that's how we'll utilize the time. Over to you,
Sure.
Dr. Vikas, please.
Yeah. Good afternoon, everyone, and I welcome you to this interesting session on clinical challenges. And we have some really interesting talks coming up, so I'm sure that it will be a very interesting time. So to start with, I invite Dr. Malika Goyal from Apollo Hospital, Hyderabad. She is going to present a curious case of bilateral painful posterior uveitis. Over to you, ma'am.
Okay. So I'd like to thank Dr. Bansal and the scientific committee of the TOS for this opportunity. So this was a 39-year-old male who presented with left eye vision drop for 6 to 12 months. And more importantly, both eyes pain with severe headache. He was tortured by the headache and unable to sleep. In fact, he wanted relief from the pain and vision was secondary to him. He also, on questioning, had history of ulcers in the mouth and genitals, skin rash off and on, no other systemic problems, and family history was significant for tuberculosis. On evaluation, the right eye vision was normal. The left eye was counting fingers at 3 meters. Both eyes anterior chamber was quiet. Vitreous cells and haze in the right eye 1+, left eye 3+, and bilateral disc edema and congestion 3+. So this was the right eye with the disc edema and congestion, hard exudates at the macula, and a serous detachment seen on OCT. The left eye severe photophobia, vitreous haze 3+, and cells 3+. Retinitis and extensive subretinal abscesses and vitreous exudates inferiorly. So we investigated him extensively with the hemogram and for sarcoidosis, toxoplasmosis, TB, syphilis, HIV, herpes simplex virus, varicella zoster, and CMV. Also for dengue, chikungunya, leptospirosis, Lyme antibodies were done, and rickettsia was investigated with Weil-Felix test. He was referred to the neurologist because of the bilateral disc edema and severe headache, and an ID specialist consultation, which was unremarkable. We also did left eye vitreous biopsy, and intravitreal antimicrobials were injected. The vitreous specimen was sent for microbiology, smears, and culture, as well as nucleic acid analysis for all viruses, acid-fast bacilli, and parasites. Everything returned negative, including the neurology investigations. Specifically, the lumbar puncture opening pressure was normal, ruling out raised ICT as the cause for headache or disc edema. CSF analysis was normal, ruling out neurosyphilis. So he was treated as migraine with no relief. We started him on oral levofloxacin because of its high bioavailability, broad spectrum action, and covering TB as well, and doxycycline to cover for possible rickettsia and Lyme. 10 days later, there was marginal improvement. The serous detachment on OCT had resolved, and the left eye vitreous haze was less with lesions more circumscribed. However, this was not enough improvement for 10 days. So now we had to reconsider the diagnosis of possible. Syphilis seemed to be an obvious possibility now because of the history of oral and genital ulcers and disc edema. Though VDRL was negative, CSF analysis was negative, and TPHA had been unavailable because the pandemic had just broken out that time in March 2020. So his test results became unavailable. And TB was also a possibility. So we treated him for syphilis now with intravenous ceftriaxone for 3 weeks. And doxycycline was continued because this is also an anti-syphilis drug. And we wanted to cover for rickettsia as well, continuing treatment for 6 weeks. And within 7 days, there was marked improvement. The headache was resolving. at 2 weeks, and at 3 weeks, his headache and genital lesions had resolved, which gave him a lot of relief. And vision had improved from 3/60 to 6/60. And you can see the picture. All activity has resolved. So basically, we finally had a diagnosis of bilateral ocular syphilis, which was the etiologic diagnosis, and the anatomic diagnosis was bilateral posterior scleritis, which we had never thought of when we were treating him, and which explained his severe pain and headache. In the right eye, the scleritis was presenting as neuroretinitis, which is a known thing, and left eye was scleritis associated with panuveitis. Now, this scleritis was posterior, that is why the eyes were white, they were never congested. So the take-home messages are that when there is a history of oral and genital ulcers, we should have had syphilis higher on the list. And when there is severe pain and headache, in any case of uveitis, retinal vasculitis, we should think of scleritis, either anterior if the eye is red, or if it is not red, then posterior scleritis, because no other uveitis causes pain, or at least as much pain. And particular about this pain is the nocturnal pain, which keeps a patient awake. So we should have done a B scan immediately to rule out posterior scleritis rather than sending to neurology for a neurology referral. And B scan is typical for increased posterior cortex thickness, retroscleral fluid, and widened optic nerve shadow, which leads to the T sign, classical T sign. Ocular syphilis can present in any form and should be ruled out in every case of uveitis, as we had a case of, in this case. Thank you very much.
Thank you so much, Dr. Goel, for a very interesting case. Definitely, it was challenging.
Thank you.
May I invite Dr. Grover and Dr. Bansal to have your inputs on the case, please?
You're muted, Dr. Bansal, you're muted.
Okay, I think that's a good message that Malika gave, that whenever you have patient coming with severe pain, scleritis should be high on your differential list. So that definitely is a point which is worth noting and keeping in mind.
In fact, Dr. Bansal, I have seen cases which have no uveitis. They just come with pain, facial pain, headache, that side eye, non-specific. There's no internal uveitis, intraocular inflammation. You just take them to B scan and you will find the choroidal thickening and retroscleral fluid. So they can have just posterior scleritis with normal fundus. And you might just say that, okay, this is just psychological, or just take Combiflam.
So B scan, you say, is a must in this case.
Very important. When anybody comes with new onset pain, non-specific headache, must do a B scan.
I think that's a point well taken. That's right. Very interesting. Yeah.
Dr. Goel, when do you want to start steroids right away, or do you want to wait with antibiotics and then start steroids? How do you start steroids in these kind of, infective scleritis kind of thing?
See, when it's obviously infectious, you would like to rule out an infection, as in this case, there were exudates and all these things. But most of the times, 95% of the times, the scleritis is non-infective. And there you can directly start steroids, and then you can add an anti-tubercular treatment or these things subsequently if there are recurrences.
So my question was specifically, so in case you start steroids right away and you have a etiology of infection in mind, do you feel that it may worsen or it may become more challenging?
Yeah, if there is any doubt that it could be clearly infective, yes, better to hold on. Just give NSAIDs like Combiflam for pain relief, Voveran, and then till you are very sure it is not infective, don't start steroids.
One quick question. It's excellent presentation. How common is Lyme disease in your area?
Actually, we found that we underdiagnose it. It's not uncommon, Lyme as well as rickettsia, because there have been cases where only on repeated therapeutic trials with various agents, we finally reached the diagnosis of these diseases, treated with doxycycline, and it cleared with a positive serology. So we have now realized we have been underdiagnosing. So I have added it to my battery of tests. For any case of uveitis, I have added Lyme serology and rickettsia serology, definitely as upfront, right in the beginning.
So I think I'll invite Dr. Vikas Mittal, who is a well-known corneal anterior segment surgeon of the country, and is doing excellent work in northern part of India. And he'll be speaking on Bowman layer transplant in progressive keratoconus. Vikas.
Thank you so much, Dr. Bansal, and I would like to thank again the whole Telangana Ophthalmological Society and Dr. Bansal for giving this opportunity. So I'm going to let's straight away go with the case. So this 20-year-old boy with a diagnosis of progressive keratoconus came for a consultation in right eye. So he had undergone penetrating keratoplasty in left eye elsewhere, but didn't have good vision, and that was mainly because of high astigmatism. His vision with contact lenses in right eye was good. He was not keen on any suture transplant in right eye. This was the tomography image, which is typically very characteristic of frank and advanced keratoconus. You can see that K has reached up to 66 diopters and pachymetry is around 300 microns. So we have a 20-year-old boy who has progressive keratoconus and corneal thickness is only 300 microns and he has good vision for contact lenses. So the management would be to stabilize this disease somehow. And what do we do with that? Cross-linking at 300 microns can be very challenging. So can we do something else for stabilization of this disease? Bowman layer transplantation has been in vogue for like 7-8 years, and the Dr. Mellis group has published 6-7 articles on Bowman layer transplant. So the basic rationale used is in keratoconus we have fragmented Bowman layer. So if you transplant a new Bowman layer, so it can stabilize the keratoconus. They found good results both in stabilization as well as some flattening in a few cases. Basically, this is surgically very challenging, and maybe that's the reason even after 7-8 years, the reports are on primarily from one center only. The other technique that has been used is intracorneal lenticule addition or stromal augmentation. So what they have done is taken out the lenticule that is removed from smile and implanted it in mid-stroma and found good results. Mainly the results were 6 months or 1 year, and they found that it can stabilize the keconus, progressive keconus. So what we did was we combined these two things and we tried to transplant both Bowman layer as well as anterior stroma. For this, we harvested 200 microns from the donor cornea, which was optically clear using femtosecond laser, and then created a pocket in recipient cornea, again using a femtosecond laser at 300 microns, and then transplanted it into the mid-stroma. Since it has both Bowman layer as well as anterior stroma, and it was placed in the in the mid-stroma pocket, we called it Bowman stromal inlay. So I'll straight away take you to the surgery, how we do it. This is a patient eye. So what we have doing here is creating an anterior 130 micron pocket using same LASIK software. What we had done is the side cut energy, we had made it to minimal so that we don't have a side cut. After that, donor cornea was placed on an artificial anterior chamber. And you can see the plan was to create an anterior 200 odd microns. First of all, epithelium was removed using alcohol. And once the epithelium was removed, the limbus was marked using junction violet. So I want to harvest my anterior 200 micron inlay within these marked areas. So you can see this. So this is the inlay. This has a Bowman layer as well as anterior stroma and close to 180, 200 microns. Now we come in a main OR. This is the patient eye where there is a pocket which has already been created. So I'm just opening up those pockets. You can see this using any blunt dissector. Then this inlay that has been harvested is placed in a IOL injector, routine IOL injector with Bowman layer side up. So so I'm injecting some fluid into this anterior stromal pocket, and using simple injector, we can inject this inlay into the pocket that has been created. And this looks somewhere similar, is somewhere similar to what we see in DSEC or endothelial transplant. So this is unfolding, massage, centration, all can be done using cannula, using surface massage and unfolding. And you can see there is no suture required and the surgery is over. This is how post-operative looks like. The interface is somewhat similar to LASIK. So there is no much interface issues. You can see the inlay is well placed in anterior stroma. This is the same patient who had 60 odd microns, and you can see from the pachymetry from 293 micron to 509 micron, and keratometry is more or less same. So this is the first 10 eyes that we have evaluated who have now is more than 2.5 years follow-up, close to few have close to 3 years. All were severe to moderate keratoconus, and they had K. You can see mean K was 56 after Paki was 385 microns. This was follow-up. Mean follow-up was 15.9 months. There was very surgical. It's technically very easy surgery. The way we do Bowman layer transplant isolated is very challenging. It's very easy. No flap related issues. No interface related issues, and you can see the pachymetry improved, and pachymetry increase in pachymetry is according to the thickness of inlay that we had used. The BCVA was same or improved in 9 patients. 1 patient had a drop of 1 line. Contact lens assisted visual acuity was same. Topography was more or less stable. A few patients, it became flatter also. You can see posterior float also remained stable. So overall, there was stability, and few patients had flattening as well. So there was no progression, just like what we achieved using collagen cross-linking. We recently published in JCRS. So what are the possibilities using this technique is we can strengthen the cornea by using Bowman layer as well as antiostoma, can stabilization of keratoconus, and few patients can have flattening as well. Future topo-guided PRK can be done. In case it's still there is still ectasia, we can use collagen cross-linking. So at the moment, there is another management for keratoconus, which results may be similar or maybe superior to CXL, and for those eyes which are not fit for collagen cross-linking. Thank you so much.
Yeah, thank you, Vikas. That was a great presentation. In your cases, you have a 2.5 year experience follow-up, you're saying?
Yeah, around 3 years now.
3 years, yeah. So is there any stromal loss that you see over a period of time? Any percent of stromal tissue gets this thinning of stroma? Does it happen, or the results are very stable?
So that's a very interesting thing, and we actually looked into it. So what we found was till 2 years there was no stromal loss so far. In one child who was 15 years old, we found that there is 10-15 microns odd, but that can be an inter-observer variability also. So far we have found that it remains stable.
Yeah, stable. So no significant.
No, not significant so far.
Yeah. And if you compare, Bowman stroma with pure stroma, implantation, is there any difference in terms of, the quality of vision? Would a clear stroma or a pure stroma would give a better quality of vision as compared to when you implant Bowman stroma?
Yes, great. So I think you want to ask that whether the interface is or this will be more with these kind of cases. So this inlays we didn't cross-link. So these were pure, and these were taken from eyes which were more than 40 years old, which is naturally cross-linked. And we didn't find any issues with the vision. There were a few patients where there was a drop in the visual acuity, best corrected, but that was because of some astigmatism, or because the refraction after that is slightly unpredictable. So but I feel that if you use more mid stroma, I don't know, so why we use this was, and antiostoma is is stronger, and then you have Bowman layer, and you are placing it into the most physiological area. So the idea was to stabilize and not the visual acuity at the moment.
And would you also think of this procedure even in cases who have got a better thickness, like can it be done in place of C3R?
Yes, I do feel so. And in fact, the first 10 eyes that we published also, I think 4 or 5 eyes they were fit for collagen cross-linking also. You can definitely do it. The idea is that you get some thickness. So later in case you want PRK, topo-guided, those things can be done. So I feel, yes, it can be done instead of in place of cross-linking as well. This can be a good alternative.
Excellent. Very, very nice results that we saw. Nice technique.
Thank you so much, Dr. Bansal. Yeah. So I think next I would like to invite Dr. Vanita Pathak Ray from Center of Sight, Hyderabad, and she's going to present a different kind of angle closure. So this looks very interesting. Over to you, ma'am.
Thank you very much indeed. One second, let me share my screen. Can you hear me, and can you see my screen?
Yes, we can hear you.
Can't and my screen, yes?
Yeah, now it's visible. Now it's visible.
Yeah.
There is a small delay from your side, so you can switch off the video if you think, and you can continue the talk. And later
Sure,
on, you
sure.
can stop sharing and switch on the video. That we'll also
Sure.
do. Thank you.
Okay, just a minute to switch off the video. Yeah. There we are. Okay, so very good afternoon to all of you. And with your permission, and I would like to declare that I have no disclosures relevant to this talk. I will straight away dive into the history of this lady, 48-year-old, who complained of bilateral eye pain with red eyes for at least about 2 weeks, accompanied nausea, vomiting. She gave history of retinal laser 4 years ago and was a high myope, about 10 minus 10 spherical equivalent. She was asthmatic, borderline diabetic. She presented elsewhere before she came to me, and she was put on 3 anti-glaucoma medication. An NCT was found to be unrecordable. And straight away, I noticed that she was on beta blocker when she was an asthmatic. So she presented with uncorrected visual acuity of 30 centimeters in the right eye and close to face in the left. She had intense ciliary congestion, microcystic edema, shallow AC, and an IOP of 72 on applanation. A very extremely difficult examination, very uncomfortable. So straight away, I sent her off for mannitol, gave her 2 tablets of diamoxtat, and within an hour, she was much more comfortable. Her pressure decreased to 39 millimeter mercury. That's when we took her photographs. You can see she had bully in both eyes and very congested in the right more than the left. More importantly, the AC was extremely shallow. And next day again, she was comfortable, though the pressure was a little high on anti-glaucoma medication, appropriate anti-glaucoma medication. I found her gonio to be closed, 360-degree pass. Mannitol was repeated because I wanted to do some investigations, including B-scan, which was within normal limits, other than choroidal thickness. And I also did a UBM, which showed a formed and expanded posterior chamber with convex irides. So this is very typical of relative pupillary block, and therefore an LPI was performed. So this is how she presented, and this is how she was post LPI. Dramatic change in her picture. Post LPI, she improved. Vision was 636, best corrected, minus 12. Left eye still stayed 30 centimeters. IOP was also relatively well controlled with maximum diamox and 2 anti-glaucomas. AC was shallow, PI was patent. Gonioscopy continued to show pass both eyes. And her lens was pretty thick with NS 1 to 2. And there was increased lens vault as well, which was confirmed on UBM. Plateau iris was also confirmed on UBM. And the fundus showed dragging, which is very typical and suggestive of ROP sequelae. And she did say that she was put in an incubator. So barrage was what the laser was all about 4 years ago. It was done to the lattice. So at day 0, her on presentation, her AC depth was way less than after PI, but even after PI, it was not very deep. And the biometry then comes into question. You can see that she was rather shallow in both eyes. Her lens thickness was quite a bit, given her age, and her axial length was relatively longer. Her fundus picture, typically drag disc and maculae, sequelae of ROP. So post LPI, of course, we had to think about management of this multiple mechanism of angle closure in a high myope, where she had relative pupillary block, plateau iris syndrome, as well as increased lens vault. So phaco-IL was definitely planned, and with it, I planned an endocycloplasty, which is a modification of endocyclophotocoagulation, where the tip of the ciliary process is targeted in order that it falls back in an attempt to open up the angle. So I'd like to share with you a brief video of this lady who was taken up only after her pressure was controlled and her pressure and inflammation was controlled. Pre-cataract surgery, I did an intraoperative gonioscopy, and you can see that no angle structures are visible. Angle appears closed. Cataract was done as per usual without any problems per se. And once phaco was completed, I repeated the intraoperative gonioscopy. And yet again, you can see that no features, angle features can be identified. IL was placed in the bag, and then a cohesive viscoelastic was placed in the sulcus. ECP was set up, and the probe, 19 gauge probe, was inserted behind the iris to visualize the ciliary processes. Once you visualize it, you target them with laser, and as you can see, the tips are targeted, so they fall away from the angle. And once all this was done, I inserted the endoscope into the AC, and lo and behold, you can see scleral spur is now visible. There is still some pass there, but inferior 180 degrees, almost 180 degrees, seem to have opened up in this format. On both sides of the pass, you can see scleral spur is visible. Viscoelastic was washed, and the surgery completed without any sutures whatsoever. Unknown in glaucoma surgery. Just to reconfirm, pre and post cataract surgery, no angle structures, perhaps angle structures visible. Eye was soft with gonioscopy. That is why endoscope was introduced, and that showed this change in the angle inferiorly. Post day one, she was 636 unaided, but pressure was controlled, but the other eye pressure went up, as you can see here as a reminder. Then week 3, she did much better, but left eye was not controlled, so that was done too. And when that was done, you can see how deep that one became too. This is day 1 post-operatively. Last follow-up, her BCVA is 618 in the right eye, count fingers 50 meters in the left eye. She is open, 180 degrees in the right eye, less than 1 quad in the left eye, and pressures are controlled. Patient is completely pain-free and anti-glaucoma medication free. There is a little bit of corneal change due to high IOP for a period of time. So angle closure is rare in myopes, but the rate is up to 10%, and the incidence is likely to increase. And we tend to miss it because of presumptions of deep anterior chamber. Gonioscopy will detect this, but does not explain the mechanism. A scan explains the mechanism with a ratio called relative lens position, which was 0.19 in both her eyes. Open angles, it is 0.23 or more. How is this explained? In myopes, due to environmental factors, iatrogenic factors, the anterior segment remains the same, small anterior segment compared to the vitreous length. The axial length is increased only because of increased vitreous length. So I conclude by saying that angle closure usually occurs in short eyes, and it remains relative rare in entity in myopes, tends to get missed by presumptions of deep anterior chamber, but presumptions aside, gonioscopy is mandatory, and it's A scan which explains the mechanism via the relative lens position. And increased axial length in myopia in environmental or iatrogenic factors is because of increased vitreous length. So angle closure eyes with multiple mechanisms are at risk of aqueous misdirection, intraoperative and postoperative. And it is this endocycloplasty which helps to deepen and stabilize the ACD, as well as control the IOP, avoiding need for any intervention for aqueous misdirection. Thank you very much.
Thank you so much, Dr. Ray. Dr. Bansal, you can unmute yourself, please.
Yeah. Okay, so I think that's a nice presentation. So the message that you are giving is that angle closure can also happen in myopic eyes. It's not that happens only in short eyes. And what I wanted to ask was that is lens restriction is a very important component of the treatment, or only the other treatment could have helped? What do you call?
Yeah, thank you for that question. Actually, phacoemulsification has been, it has been said that itself should be sufficient for angle closure, especially acute angle closure. But here I was seeing peripheral anterior synechiae as well. So I wasn't sure that phaco alone would control, and perhaps later, if I hadn't done the endocycloplasty, I may have considered one later, or maybe done a filtration. But I have looked at my own data of phacoemulsification alone versus phacoemulsification with endocycloplasty. And endocycloplasty is definitely superior in terms of controlling IOP at a much more significant rate than phaco alone.
Dr. Goyal, you want, please?
Yeah, I just wanted to say that it was very good presentation, Dr. Vanita. And ROP has been known to be associated with angle closure glaucomas in the later in life, after the age of 30. So any patient we are following up with ROP should also be looked at with this possibility. And any case of angle closure glaucoma should be looked at with a history of ROP. And lens is an important factor in these cases because it creates a relative microphthalmos, anterior microphthalmos. And so the lens removal, most of the times the iridectomy may suffice, but in a large proportion of these cases, lensectomy, even in younger patients, lensectomy is required.
Yeah.
Dr. Ray, can I ask a quick question?
Of
we
course.
have been doing this for the last 3-4 years, and what we found was that in the beginning phase it decreases the IOP, but after 1 year, it increases, the pressure increases again. And second thing, what we found was there was increase in the inflammation. So I don't know if we are not doing something correct or any inputs on that.
Laser parameters are extremely important. There is no doubt about that. And the study I'm talking to you about phaco alone versus phaco endocycloplasty has shown, and was done at 1 year actually post procedures, and has shown that it continues to stay valid at 1 year. So laser parameters are important. Inflammation, you can get fibrin. Definitely, you need to use steroids at a higher dose without being worried about a steroid response in the early stages. So I have a very strict regime for these eyes. I also keep them on Diamox. I take away all topical anti-glaucoma medication. I keep them on Diamox for a few days, 3 to 5 days, and I keep them on very high dose steroids, topical steroids. And I have been able to control it. I mean, you can see in this particular eye, which was acute angle closure, she did pretty well just with the inflammation was controlled pretty well only with topical steroids.
Thank you so much. Yes, Dr. Goyal, please.
Yeah, just a quick point. Diamox sometimes can cause paradoxical angle closure and raised IOP, which we have also seen. So just wanted to make that point.
But that is an idiosyncratic reaction where you will get ciliocoroidal effusion. Remember, we did both B-scan as well as UVM. We did not see significant ciliocoroidal effusion. Of course, angle closure eye, especially acute angle closure eye, will get a small amount, which is something I did mention, that choroid was marginally thickened.
Yeah. Thank you so much. I think in the best interest of the time, we might have to move forward. Now, I would like to invite Dr. Divya Natarajan from Hariprasada Institute, Hyderabad, and we are going to see an interesting case of cyclovertical strabismus. Over to you, Divya.
Yeah, thank you. Good afternoon, everyone. I'd like to thank Dr. Bansal and the Telangana Ophthalmic Society for giving me this opportunity. Are my slides visible?
It's loading up.
Is it all right now?
Yes, ma'am.
Right. Okay, then today I'll be presenting two interesting cases of cyclovertical strabismus. Both of these cases presented to us in the last 2 months with very different etiologies and with troublesome vertical diplopia. So the first case is that of a 5-year-old female child that complained of binocular double vision since 1 day. The child was very precise about this. There was no history of trauma, no systemic illness, and no other neurological symptoms. And her previous photographs revealed that there was no anomalous head posture previously, and eyes were looking straight. She had a very clear right face turn with a small chin elevation for both distance and near when she presented to us. Also, on palpation, there was definite tenderness in the left trochlear region. So we were thinking on lines of Brown syndrome. However, since the presentation was just 1 day old, we wanted to look further. So a motor examination also concurred with our findings of Brown. So she had a very small left hypotropia in primary. However, on ocular motility checking, her left eye showed a marked limitation of elevation in an adducted position compared to an abducted position. So all the more, this diagnosis was going towards the Brown syndrome. So we did a B scan just actually as a routine protocol to rule out any other cause of restrictive pathology. And to our surprise, we found that there was a hypoechoic cystic space in the superior nasal quadrant. We went ahead with the MRI. MRI brain was normal. However, MRI orbit showed that there was a small hyperintense lesion in the superior nasal quadrant in the left eye, and there was what appeared to be a small hypointense lesion inside. So that was suggestive of cysticercosis. So with that in mind, keeping cysticercosis as our first etiology now, we started the child on treatment. She was started on oral albendazole, 15 milligram per kg per day, and along with oral steroids and tapering doses. So subsequently, we saw this child after 3 weeks and then again after 6 weeks. On both follow-up visits, there was no improvement in ocular motility noted in this child. There was just a small, the left hypotropia in the eyes seemed to be slightly better in the follow-up visit, but the motility had just not improved. So this was a case of a left-acquired Brown syndrome, and even now we are not very clear about the etiology. She has been now posted for an intratrochlear triamcinolone acetate injection. However, the parents do not want to go for it now, and they just would like to observe for some more time and come back. But this presented a diagnostic dilemma for us. One possibility that we thought was probably there was cysticercosis, which may be resolved but not completely. The inflammation surrounding that lesion apparently has not resolved, and maybe that is why the motility in the left eye is still not improved. So this was one case. The second case is a more recent presentation. She presented to us 1 month back. She was a 28-year-old female. She had a vertical double vision since just 3 days. And the only antecedent event that she reported that was significant was that she was vaccinated 1 week back. She said she was perfectly fine. She had no other symptoms. She had no systemic illness, and she had no other neurological symptoms. On examination, on performing the cover test, she had a very small right hypertropia, which was slightly increasing in the right gaze, but was persistent in every other gaze. Initially, we thought maybe this seemed like a superior oblique palsy, but since the tilt was normal and for near also this much of hypertropia persisted, and the motility was full in both eyes, we were wondering what it would be. At this point, we wanted to know whether the brain there was something else happening. So we did the MRI brain, but the MRI brain was normal. History was revisited. She very clearly said that there was no diurnal variation, that the symptoms persisted, and there was no history of trauma. We did the IcePack test because myasthenia was one of our first differential diagnosis, but that proved to be negative. Fatigue test was also negative. In extraocular mesial paralysis presenting as myasthenia, usually this doesn't. Usually this is negative. So we didn't know what else to do. So we just decided to keep her under close observation. She came back to us after 1 week. In this visit, however, the hypertropia seemed to have slightly increased in the primary gaze. But what was more significant was that there was a depression limitation in the right eye that was almost measuring to about -2. So this variability pushed us towards the diagnosis of a possible ocular myasthenia. So we sent her for a serum acetylcholine receptor antibody test. That, however, came to be negative. We know that is a positive only in 50% of the cases, and she has been sent for a MuSK antibody test. However, repeated nerve stimulation test was positive in her case. So in view of the variable presentation, variability in clinical findings, as well as the repeated nerve stimulation test, we decided to start her on treatment of tapering doses of oral steroids along with oral pyridostigmine. She came back to us last week, and there was perfect improvement in all her symptoms. So this was a case of ocular myasthenia, but we are still not sure about the etiology. Either it could have been just an ocular myasthenia, or could it have been post-vaccination? This was one of our possible diagnoses, because vaccination can interfere with the molecular mimicry that usually can maybe affect the neuromuscular junctions. So the take-home message is that a vertical or a torsional diplopia and an anomalous head posture will suggest that possibly it's a cyclovertical muscle involvement. Cysticercosis has to be kept in mind, especially in endemic countries, and that has to be treated. Many cases, that will be the cause of the cyclovertical strabismus. And finally, ocular myasthenia is a great mimicker. It can mimic as any extraocular muscle paresis with or without ptosis. Thank you.
Thanks so much, Dr. Rajan. That was really a very interesting case. Dr. Bansal, Dr. Grover, do you want to ask anything or your inputs on the case?
Very interesting
I'm
cases.
totally illiterate in this subject. Anybody else can have any comment? I know.
Both were interesting cases. In the first one, Dr. Natarajan, did you repeat an MRI after 6 weeks to see if that lesion had changed?
No, we did not repeat the MRI. We just repeated the B scan. And that also showed that there was a little bit of hypoechoic specs still persisting. It seemed to be smaller than the previous one, but it had not resolved. So we are really not very sure what it could have been.
So maybe if there are no more questions, can we go on to the next presentation, please?
Yeah.
So it's my proud privilege to invite Dr. Sandeep Grover from University of Florida, and won an interesting talk on I can't see. And thank you so much, Dr. Grover, for coming up, although the timings are really odd, but thanks so much. Over to you.
Well, thank you. Thank you very much, Dr. Bansal, Dr. Santosh, and the TOS team for inviting me to be a part of the Ranga Reddy session on clinical challenges. It's an honor. So I'm presenting this patient, AC, who is a 14-year-old girl who was referred to me by a pediatric ophthalmologist, and for progressively declining visual acuity and night vision problems. She did have a history of congenital nystagmus and headache. So the previous history with the pediatric ophthalmologist was that at age 11, she had come in with a vision of 20/70 in the right eye, 20/50 in the left, slightly myopic. At age 13, 2200 in the right eye, 2100 in the left eye, the increasing myopia. So at age 13, when she was examined, they found a mild temporal pallor in optic nerves, peripheral retinal mottling. So did a Goldman visual field with severe constriction of fields to less than 30 degrees in both the eyes. They did an MRI of the brain, did not show any space occupying lesions. Did an ERG because of the visual field being down, and they showed a moderate decrease in the rod and cone function, and so established a diagnosis of retinitis pigmentosa. Because of the vision, they declared her legally blind. She was recommended to join the Florida School for Deaf and Blind instead of a regular school. They also did some gene testing for the known genes for retinal degenerations, and it was negative for all known genes. 1 year later, she presented to them with further declining vision, count fingers in the right eye now, and maybe NLP in the left eye, and no change in the eye exam as such. That's when they referred the patient to me. So when I saw her, the vision was, according to my technician, the right eye count fingers at 4 feet and left eye count fingers at 3 feet. Again, myopia, astigmatism. The pupil exam was normal. The anterior segment was normal. In the posterior segment, I saw a diffuse hypopigmentation of fundus, like a blonde fundus, but then the patient was a blonde as well. And we see that often. And prominent choroidal pattern because of probably high myopia. There were no cells in the vitreous, no pigmented cells. Optic nerves to me looked normal, and except that there was a temporal crescent, and the caliber of retinal vessels was normal, no bone spicule pigments. So we looked at the OCT, and I could only get a line OCT because of nystagmus, but the macular area looked pretty good in both the eyes, with the ellipsoid zone and the photoreceptor areas were good as well. So I did a fogged refraction in my office, and with this retinoscopy, I tried put in the phoropter, built up a story, and I got the patient to read 20/30 in both eyes. So I diagnosed the patient as a functional vision loss or a non-organic cause of vision loss, and did a Goldman visual field in our office, which showed very typical features of functional vision loss, very constricted fields, non-physiological fields where you get a bigger size field with a smaller size target, if you look at the color code. And the third is called the spiraling field, where the field keeps going in spite of using the same target size. So I explained to the mom and the child about how this can be caused by stress. Mom immediately jumped on it and said her daughter has been under a lot of stress for a few years. Age 11, girl's dad was diagnosed with skin melanoma. He passed away when she was age 12, and mom remarried at age 14, and the patient does not get along well with the stepdad. I just reassured the patient and her mom that she did not have a blinding disease. Examined the patient in 3 months again. Subjectively, she was improving. Visual acuity was slightly better. So usually, if it doesn't happen in 3 months, I recommend a psychiatry consult as well. Examined patient after 2 years, she was lost to follow up. The vision had improved to 20/50. This was a different girl I saw in 2 years. The vision had improved to 20/50, of course, not normal. She did not feel that she had a vision problem. She was going to a regular school instead of a blind school, and she was participating in sports, gets psych counseling at regular intervals. So functional vision loss, some people do it for malingering, for a secondary gain, like applying for visual disability or litigation, like court case or something. But what I have seen in my experience, that most of the people actually are not malingering. They just start believing that they can't see. And of course, stress is the number one cause. Stress can be at work, home, school, sibling rivalry, death or chronic disease in the family. The patient may have chronic disease, poor relationships, financial stress, and so on and so forth, a long list of causes. Some of the important pointers for this diagnosis is, first of all, you have to have a high index of suspicion. And secondly, the visual acuity loss is out of proportion to the eye findings. Sometimes you can get a hint of secondary gain while you're taking the history. They are very suggestible during history taking process. There is usually a history of fluctuating vision. It's pretty common. I tend to observe the patient, how they behave in the examination room, and sometimes I will even follow them out to see how they are navigating my waiting area, how they check out, and how they go to the elevator by themselves. Usually the eye exam will be normal, although sometimes there can be some mild disease or a functional overlay. And I always say, don't forget to examine the cornea, because I have a few patients where they could not be corrected, unexplained vision loss, and they had an early keratoconus, but no one looked at the cornea, since we have a couple of cornea people in here. The test for structure of retina and optic nerve use the OCT and OCTA. And for visual function, fogged refraction. For visual acuity, you can check the potential vision with a PAM or laser interferometry. Visual fields can be done with Humphrey or Goldman. And then ERG sometimes, or most of the times actually, I do it to prove that the retinal function is good, depending on the case, full field versus multifocal ERG. So depending upon the severity of vision loss and whether it is monocular or binocular loss, there are so many other tests that can be done. So important consideration is listen compassionately to the patient, have confidence in your findings. I tell the residents that what appears to be normal can be normal too. So have confidence that what you're looking at is normal. Never confront the patient. That doesn't get you anywhere. Misdirection during the testing. So I build up a story when I'm doing the fogged refraction, and repeatedly telling them that there is a problem and that you are trying to establish a diagnosis. Sometimes scare tactics helps, like telling them if you cannot do the fogged refraction part, then you might end up getting an MRI or a spinal tap. So treatment, reassurance, words of encouragement that you're not going blind if they are not. Treatment of other symptoms like dry eyes, prescribed glasses, since I've done a retinoscopy and a refraction. If it is different from what they're using, I would prescribe glasses and refer to psychiatry if not getting better. So sometimes I can't see can be that the mind cannot see, not because the eye cannot see. Thank you very much. Sorry for going over time.
Thanks, Sandeep. That was a very, very interesting talk. So I think a very important message that we should not accept all the diagnosis made by somebody else, and one should apply one thinking mind to, arrive at a diagnosis to help the patient. And it was very interesting comment that you made that you should never forget to look at the cornea, because normally the retina specialist taunt the cornea specialist that you always forget to look at the retina. So for a change, you also said that you should the retina specialist should not forget to look at the cornea either. Thank you. It was very nice.
I had a patient who was diagnosed as optic neuritis and then MS, treated for 7 years for MS. And when she came in, the only problem was there was a high astigmatism and a pre-keratoconus kind of picture. Right. So when I corrected it in refraction, she was 20/20 and there was no MS and there was no optic neuritis. Mm-hmm. So very, very important to look at the whole eye rather than just what we are used to as a retina specialist.
That's very true.
So
Dr. Goyal, please.
Yeah. Excellent presentation, doctor. And we often come across these patients, either in our situation, they are many times malingering to go off duty, etc. And you made excellent points about observing the patient unobtrusively. I often ask my staff to keep an eye on them in the waiting room where they don't know they are being observed. So while the staff is working around, they keep an eye on this patient and they can find that he is able to find his way to the water cooler or navigate between the seats. And when they're walking into your room, you can ask you can ask the attendants not to help them. And you'll find they do not collide with the furniture and they find their way to the chair safely, though slowly. And Absolutely. If you ask them the name very casually, they'll have an excellent eye contact. Whereas they are sometimes pretending to be PL negative or something like that, they cannot avoid the eye contact when a question is asked, or they are deliberately avoiding eye contact, which also you can make out. It's not a blind stare, wandering stare at all. So these are the things. And then when you do a Humphreys visual field analysis, there will be excessive false negatives, which will be shown on the top, more than 20%, showing that they were deliberately not responding. So these are the different things that even when you send them for electrophysiology, if you write the diagnosis, the electrophysiology technician knows that, okay, there is a possibility of a malingering or a functional loss. So they try to, their testing is more accurate. So that's what another thing which you have to, I would like everybody to keep in mind.
All of the above is true.
Thank you.
Thank you so much. Thank you so much. I think that what appears normal can be normal is a wonderful take-home message. So going forward in this Ranga Reddy session, may I invite Vaibhav, Dr. Vaibhav Sethi from Anurodhya Desert Eye Hospital in Gurgaon, and he's going to put forward a perfusion puzzle in front of us. Over to you, Vaibhav.
Thank you. After a number of interesting presentations, I'll also be presenting an interesting case. Can you see my slides?
Yes.
Yes, sir.
Thank you very much. So this is a perfusion puzzle which had puzzled me, and I did come to the end point of it. And I hope you're also intrigued by the case. So it was a 74-year-old male with right eye decreased vision and having floaters since a month. There was no systemic illness, and he was a known case of open angle glaucoma on timolol eye drops twice a day. On examination, the right eye had hand motion vision with accurate PR, and the left eye was 20/20. The eye pressure with the applanation tonometer was 24 millimeters of mercury in the right eye and 14 in the left eye. Anterior segment showed PCIOL in both the eyes. The rest of the anterior segment looked the normal limits. Gonioscopy wasn't done initially. This was the fundus picture. So in the right eye, there was a haze. There was a vitreous haze, somewhat due to dispersed vitreous hemorrhage, and the details were not clear. And the left eye, as you can make out, there's a disc with obvious cupping and glaucomatous disc, and the vessels and everything else was seen very clearly. So the other thing that I saw in the mid periphery was there were multiple areas of peripheral dot and blot hemorrhages in the right eye, which were not there in the left eye, and inferiorly there was dispersed vitreous hemorrhage. So there was a bit of confusion. So I did an angiography just to think maybe I'll find something on the angiography. And I was quite surprised on my findings. So at 1:05, you can see, you can compare the right eye with the left eye. You can see the right eye is still not perfused. The choroid as well as the retinal vasculature is just started to get perfused, while the left eye is totally perfused and in arteriovenous uh, uh, part of the cycle. And you can see the right eye, how it's getting perfused. At 1:45, this is the amount of perfusion there is. At 2:14, you can see this. There's still not perfusion happening at the choroid as well as at the retinal level. The vasculature is not getting perfused. There's significant amount of capillary dropout in both the layers. So at 5:08, this is the picture. It's still not perfused, and 5:53. So it's now there's diffuse leakage happening all across, and there is staining on the vessels. However, the perfusion hasn't still completed. So I went back and did a gonoscopy just to maybe to find something, and I did find in the right eye there was angle neovasculature, NVA. However, there was no NVI on initial examination. Both eyes had open angles. The provisional diagnosis which was put forward was right eye ocular ischemic syndrome, because it was something which was fitting in this category. However, the vascular dilatation in the right eye wasn't that much as compared to the left eye, the venous dilatation, sorry. So when the patient was suggested a carotid Doppler study, the patterns did suggest of atherosclerotic changes in the right common carotid artery with reduced flow through the right common carotid and with a stenosis of more than 90%. This was the picture, and you can see on the this was a CT angiography, and you can see there's stenosis, and there was a common carotid plaque on the right side with ulceration, focal stenosis. So the management now was gave an injection of intravitreal ranibizumab or any anti-VEGF. In this case, I gave ranibizumab, and then the plan was to proceed to the right eye pan-retinal photocoagulation to deal with the capillary non-perfusion in the retinal vasculature. And the patient was also advised to get the treatment done for the right-sided carotid endarterectomy. This was the picture 1 week post the injection. The vitreous haze had disappeared, and this is the picture of the right eye. You can see the vessels, and you can see those mid-peripheral dot hemorrhages, and the NVA also cleared up. However, also one thing which was seen was in the arterioles, there was multiple emboli that was seen in the right eye, which wasn't seen initially because of the haze. So the follow-up patient was doing well post the PRP. A PRP was done in the right eye. Patient had undergone endarterectomy as well, but later on I got to know from the patient's relative, and patient did not come back to follow-up, that the patient actually had passed away with an episode of myocardial infarction happening later on. So just something which was something you don't see very commonly, which you normally tend to think of in the lines of central vein occlusion or other features, but you kind of tend to underdiagnose ocular ischemia in your daily practice. So this has a significant amount of effect on the patient's longevity as well, because earlier diagnosis and prompt treatment may save the patient's life and also the vision. Thank you very much.
Thanks so much, Vaibhav. Wonderful case. Dr. Goyal, do you want to put any comments or speak anything about it?
Yeah, this is an excellent case. Whenever we see an elderly person or even a middle-aged who has been tobacco chewing, so these are the predispositions. They may not be diabetic, but they can still present with a neovascular glaucoma, and we should not be taken aback. If the pressure is high, do a gonioscopy. We can miss neovascularization iris. Do a gonio. You might find ANV in many of these cases with open or closed angle. And then if the fundus looks normal, it is an ocular ischemia syndrome with neovascular glaucoma. So yes, this happens. And then you have to be aggressive in your investigations, carotid being the main. And the entire anticoagulation, antiplatelets, cardiac evaluation starts to protect the patient's life. And the eyes require extensive PRP with anti-VEGF. So yes, being a non-diabetic does not mean that you cannot have a normal fundus with neovascular glaucoma.
Dr. Ray, you want to make a comment on that, please?
Yeah, actually, I wanted to ask Vaibhav, how many months or years after his phaco for this patient? Do you remember?
I think around more than 5 years.
Oh, 5 years, okay. Because I have a similar presentation of a physician who was a diabetic, and the only recent history was drastic reduction in weight. And he presented with high pressures, he presented with neovascularization, he presented with, fundus changes, very, very minimal fundus changes, no vitreous hemorrhage, but he had to be worked up for neovascular glaucoma, and he ultimately required a tube for management of his eye pressure. So that is still a mystery to me, and I wondered why.
I think we are running short of time. Dr. Bansal, do you want to conclude, please?
Yeah, I think the co-chairman Sandeep will conclude.
Yes, very interesting cases. Thank you, everyone, for bringing this to the panel and to everyone. And I think there was a very good group of cases. Thanks, Raj, for coordinating everything. And thank you, everyone, again. Have a nice day.
Thank
you so much.
Thanks to
Thank
all
you all.
speakers and to Vikas for moderating. Thanks a lot.
Thanks so much.
Thank
Over to you, Raj.
Yeah, thank you. A big thank you to all the moderator and our chairpersons. Well done.